My pleasure to introduce Dr. Radisky from the Mayo Clinic in Jacksonville, Florida. Derek did his undergraduate and graduate work at the University of Utah. He actually got his PhD in the pathology department there, working in a yeast lab, which, as Derek was joking around last night, is not exactly a model organism for interactions with the extracellular matrix. But nonetheless, Derek decided that it was a good idea to head west for his postdoc, and he managed to land in the Bay Area in Mina Bissell's lab, which was kind of two good places to land. For those of you that aren't familiar with Dr. Bissell's work, she's one of the pioneers of characterizing how the extracellular matrix can contribute to both tumor development, initiation, and tumor progression, and especially in breast cancer. So now in his own lab, Derek is basically working on similar mechanisms, similar concepts in a number of cancers, including breast, lung cancer, and then, as we were talking last night, cholangiocarcinoma to some degree as well. So as a member of the Mayo Clinic, Derek is also an investigator in the Mayo benign breast disease cohort study, and so he works very closely with pathologist Dan Vischer, that I think is familiar to many of us in this room, breast pathologist at Mayo. The point of that study is to try and define both biomarkers and or pathologic characteristics of benign breast disease that can be predictive of subsequent breast cancer development. And so Derek's actually a repeat offender in the Grand Rounds program. I think he gave a talk here a little under a decade ago, maybe 8-9 years. We were trying to figure it out. No one can really quite remember. But Derek came up with the invitation of Kaylee Schwartfinger and myself. Kaylee and I invited Derek, and he graciously accepted to be a key collaborator on our innovation award from the department to move forward with similar concepts of how we're trying to understand how stromal factors, inflammation, fibroblast activation within the microenvironment promote breast cancer progression. So without further ado, Derek, please, everybody help me welcome him.
Wow, thanks, Andy. That's the best introduction ever. I feel like I don't even need to talk now. So is there any questions? Okay, so let's make sure we're on track. So the work I'm going to talk about today is the product of the benign breast disease group at the Mayo Clinic, which is a consortium of surgeons and pathologists led by Dan Vischer and clinicians and breast cancer people, as well as basic cancer biologists such as myself. And our goal is to better identify from among all women those women that are most at risk for developing breast cancer. We think if we can identify these women, the ones that are likely to go on to get cancer, the result is going to be reduced breast cancer incidence and, as a consequence, mortality, because we'll be able to perform better surveillance, earlier detection, and more optimal cancer prevention therapies. The problem with doing this now is that current models for risk prediction that are developed on the population level and work well at that level perform very poorly for individualized risk prediction. So the best known risk model is the Gale model. It incorporates variables such as age, race, age at menarche, age at first live birth, first-degree relatives with cancer, and a number of breast biopsies. And this model is viewed 30,000 times a year on the NCI website, which speaks to the desire to get this information, even though it performs very poorly at the individualized level. In a study using the Nurses' Health Study, they found that there was a C-statistic of 0.58, meaning that there's a 58% chance that the Gale model accurately predict a nurse that developed breast cancer having a higher score than one that didn't develop it. And this is better than chance, but not by much. So how can we improve on this? How can we do better than this model? Well, in optimal risk prediction is possible when we have histopathologic assessment of the tissue at risk. With cervical, colon, esophageal, and bladder biopsies, even in benign biopsies, there's information present that can indicate whether that individual specifically is going to go on to develop breast cancer, go on to develop cancer of their tissue. Why can't we do this with breasts? Well, we can. In the U.S., there's 1 to 2 million women a year who have biopsies, palpable lesions, mammographic abnormalities, and of these women, there's 250,000 positive findings of breast cancer, and there's established clinical guidelines for these women, but the remainder are classified as having benign breast disease, and this is more than 1 million women per year. And these women, by virtue of having benign breast disease, are known to have about a 50% elevated risk overall. Sorry.
No, I think about 10 players, you're doing fine.
Yeah, but then what if I move away from it then?
Then I'll just have to get up and move it back.
Right. known to have 50% elevated risk overall for developing breast cancer, meaning that about 15% will go on to develop cancer and 85% won't. How can we identify which of the women in this group are likely to go on to develop breast cancer? Well, we're doing this in the context of the Mayo Clinic benign breast disease cohort. This is a cohort of now 13,500 patients who were diagnosed with benign breast disease, BBD, at the Mayo Clinic between 1967 and 2001, for which we have, for most of the patients, the original biopsy blocks and extensive clinical histories, as well as questionnaires, and of which 1,273 have subsequently been diagnosed with breast cancer. And through this, and with a 15.8-year median follow-up, we're able to differentiate between those patients that are truly benign and those that are pre-malignant. Now, one thing to know is that BBD represents a range of disease pathologies. So the model of progression to breast cancer normally goes like this: from normal terminal ductal lobular units through non-proliferative disease, proliferative disease without atypia, atypical hyperplasia, and then DCIS and invasive breast cancer, where everything past TDLUs and before the carcinoma in situ is classified together as benign breast disease. And they're usually linked up together in a sequence like this, in part because of increasing histological derangement along this sequence, and also because of increasing relative risk for subsequent progression to invasive breast cancer. So it's seen that this is the model for progression. So the overall goals of the breast disease cohort working group are, first, to define the factors that define the earliest stages of BBD. What is it that's involved in changing from being normal breast to abnormal? Then, what are the key steps that define progression from benign breast disease to cancer? What are the tissue interactions that block or facilitate this step here? And then, knowing that, what can we do to reduce breast cancer incidence and mortality? How can we better identify and treat those women who are at risk? And for today's talk, I want to talk about three general areas of investigation that are going on in the group: defining atypical hyperplasia as a breast cancer precursor, identifying stromal alterations that distinguish benign disease, truly benign disease, from malignancy, and defining delayed age-related lobular involution as a breast cancer risk feature. So first, atypical hyperplasia. So atypical hyperplasia, or atypia, is diagnosed in about 100,000 U.S. women per year, and these women are known to have a substantially elevated risk for subsequently developing breast cancer. We think of atypia as being a critical step in the development of breast cancer for a number of reasons. One is that normal breast tissue from BRCA carriers or other high-risk individuals often contain atypia, and examination of genetic and epigenetic profiles in atypias, DCIS, and invasive breast cancer shows similarities and progressive alterations, indicating that it's a process of development. So we made a number of findings in the BBD group associated with atypia and risk. One is that the risk from atypia is stable, it persists. It used to be thought that after 10 years the risk following atypia tailed off, but we now know that it continues out to at least 25 years and can be stratified by the number of atypical foci present in the biopsy. So for women with one atypical foci, the 25-year risk is about 23.9%. Up to those women with 3 or more foci, the risk is almost 50%. Another thing to know is that while atypia is classified into distinct histological subtypes, for ductal or atypical ductal hyperplasia or lobular or atypical lobular hyperplasia, it used to be thought that these represented pathways to lobular cancers or ductal cancers, and we now know that's not so. That for those patients with atypia who do subsequently develop breast cancer, that there's similar profiles. So this chart shows the kinds of cancers that occur following a diagnosis of atypical ductal hyperplasia or lobular hyperplasia, whether the subsequent cancers are ipsilateral or contralateral, and whether they have a morphology of ductal, lobular, or other, and other in this case means mixed, ductal and lobular. And what you can see is whether they have ADH or ALH, they have roughly equal amounts of ductal and lobular cancers that follow from them. So these represent markers of risk more than histological precursors. So we're working so atypia is a high-risk lesion, There's good news and bad news about that. The good news is that it's pretty easy to reduce risk in patients with atypia. In a study from Mass General that had 3,000 atypia patients, of which 1,280 had chemoprevention, usually tamoxifen or raloxifene, they found that there was about a 2/3 reduction in breast cancer incidence at 10 years for those patients who did the chemoprevention. So it's possible to prevent the breast cancer, to largely attenuate it. The problem is that the uptake of these chemoprevention is very low, in part because women don't perceive themselves as being at increased risk, and also because their individual perception of risk is seen as low, so the risk-benefit doesn't seem worth it to them. And this is in part because the models are particularly poor at predicting risk for women with atypia. The Gale model has a C-statistic of 0.5, and we found that the Tyrer-Cuzick model has a C-statistic of 0.54 when applied to women with atypia. So to try and improve on this, we've been taking two general approaches. First, to look for immunohistochemical markers that we can use to stratify risk. And second, looking at profiling approaches to identify gene signature models. So first, immunohistochemistry. We found a number of markers that stratify risk, in some in interesting ways. Ki-67 stratifies risk in a time-dependent way. So if you have more than 2% Ki-67 in your atypia, you have a high degree of risk for developing cancer in the first 10 years, and this risk tails off. Whereas if you have less than 2%, then your risk is low for the first 10 years, and it climbs rapidly after that. So you can do risk stratification according to time using Ki-67. We found that P16 doesn't predict risk, even though it has been shown to do so in DCIS, and also that ER-alpha isn't associated with risk. But unlike ER-alpha, we found that ER-beta does predict risk. So ER-beta is an isoform of ER-alpha that's generally perceived as being anti-tumorigenic. So it's seen that more ER-beta would attenuate the tumor process. And that is what we see here. So patients with low ER-beta in their atypias have higher risk of cancer, whereas people with higher levels of ER-beta have lower risk. But what was interesting is that while this is a hazard ratio of 2.0 for the atypia lesion, if you look in the surrounding tissue, then the risk is the stratification is even stronger. So looking at the normal lobules that surround the atypia, if you stratify them into low versus high levels of ER-beta, the stratification gets better. And when you combine them for low in the atypia and the surrounding lesion lobules versus high in both, you can push the hazard ratio out to 3.7. So by considering the entire tissue, we can do further stratification of risk. So this is immunohistochemical markers. A parallel approach we've been taking is to get gene signature prediction models, and this is work that's underway. So you'll have to forgive me if it's not all the way finished yet. But the initial results are pretty exciting. So what we did was we identified a cohort of women who had atypia, some of which progressed to cancer, which we call cases, and some of which didn't, which we call controls. Then we got the RNA from whole tissue sections of the benign biopsies, the atypia-containing biopsies, did dazzle microarrays, and generated a diagonal linear discriminant analysis, a DLDA predictive gene signature from the differentially expressed genes. And doing that, we saw that while there were 1,406 differentially expressed genes between the controls, the atypias that didn't progress to cancer, and the cases, that the optimal number of probes for prediction was 40. And while the identity of these probes is, as usual, sometimes meaningful, ADAM10 is one of the markers, there's many that don't have any really clear intuitive sense. But when we apply this predictive signature to the training set that we use to generate it, we see that it does a very good job of predicting the case or control status of the patients. Almost all of the true cases are predicted as cases, and almost all of the controls are predicted as controls. When this is expressed as a survival analysis, it has a hazard ratio of 6.6, and the model allows us to stratify risk, in addition to saying just risk high or low, to stratify risk here using a spline. We can see the 10-year risk percentage by different scores that are coming out of the model metric, from 17.6 to 53.5%. So what we're currently doing is testing this model in a validation set and developing a nanostring-based assay so that we can use this in the clinic. And then once we have this, we're going to incorporate it into a risk prediction model that also includes immunohistochemistry and clinical variables for optimal individualized risk prediction. So next I wanted to talk about stromal alterations that distinguish benign disease from premalignancy. And stromal alterations covers a lot of ground. But what I wanted to talk about here was myofibroblasts. So in cancer, increased myofibroblast accumulations associated with increased stage, distant metastasis, and poor prognosis. This is an image of a pancreatic cancer because it's one that I had easily available to me, but the general principles are the same for most cancer types, including breast, that in the normal tissue, there's not many myofibroblasts, as seen here with the smooth muscle actin staining, whereas in the high-grade cancer, there's many myofibroblasts. So in cancer, myofibroblasts are seen as generally bad. But what role do they play in the transition from benign breast disease to malignancy? Well, this is complicated. I'm going to illustrate this using two different subtypes of benign breast disease. One, pseudoangiomatous stromal hyperplasia, or PASH, and sclerosing adenosis. They're similar in that they're both characterized by myofibroblast accumulation and collagen deposition, but they have very different outcomes in terms of their breast cancer risk association. So first, PASH. PASH is defined as nodules of collagen that contain within them and fibroblastic stromal cells and epithelial lobules with a simplified unfolded structure. Now, we found PASH in 579 of 9,000 benign biopsies assessed, or about 6.4% of the total, and primarily found PASH in the pre- and perimenopausal women. 10.4% in those under 45, 7.9% in those 45 to 55, and about 2% in those 55 and older. When we looked at the risk association for patients with PASH, we found that patients that had PASH had substantially reduced cancer risk as compared to non-PASH benign breast disease patients. So when we compare to the Iowa-SEER, which adjusts for patient age and for time of follow-up, patients with no PASH have a relative risk about 1.54 relative to the general population, which is typical for what you see for benign breast disease, whereas PASH has a relative risk of 1.03, the same as people without having BBD at all. So in this case, having this lesion is reducing your risk relative to patients that don't have BBD at all. By contrast, sclerosing adenosis. Now, sclerosing adenosis is an accumulation of both epithelium and myofibroblasts, and that leads to these compressed and crowded gland-like acini. This is an SA lesion by comparison with a normal lobule over here, and they can get quite large. This is a fairly small one. We found it in 3,700 of 13,000 benign biopsies, so about 27.8%. It's more abundant in peri- and postmenopausal women, 21% of women aged 45 or less, 34 of 45 to 55, and 28 of those 55 and older, and also slightly more abundant with increasing parity, from 25% of nulliparous women up to 31.9% of those with 3 or more children. And when we looked at the risk association for sclerosing adenosis, what we saw is that there's about a 2.2-fold elevated risk for patients with SA by comparison with the general population. And this carried through across all subpopulations. Here we're looking at those for women under 45, 45 to 55, and greater than 55. And in every case, patients with sclerosing adenosis had a higher degree of risk than patients without sclerosing adenosis. So based on this and other studies, we're proposing that sclerosing adenosis is the key PDWA lesion on the pathway to breast cancer. So we're doing immunohistochemical studies here too to try and do risk stratification, but we've recently published a study where we're doing gene signature prediction here that's similar also for SA. Again, we made a cohort of cases and controls, this time of women with SA, did the whole tissue section, the DAZZLE, the DLDA predictive signature. This time, the optimal number of probes was 35, and it performed well in the training set. It had a C-statistic of 0.91. Not as well, but still pretty well in the validation set with a C-statistic of 0.84. For classification, it did a very good job of predicting the cases as cases in both the training and the validation set, and not so good at predicting the controls as controls. They fell on both sides of the line. And when expressed as a time to cancer, it had a hazard ratio of 3.5 for the training set and 2.2 for the validation set. So, taken together, what the conclusion from this is that different histologies have different outcomes of risk. And while this seems kind of reflexive and obvious, in at least the basic breast cancer literature, it's commonly seen that commonly viewed that myofibroblasts are bad, and that's not always true. Myofibroblasts in the context of PASH are associated with reduced risk, and in the context of sclerosing adenosis are associated with increased subsequent risk. So the context is critical here. Another thing is that the transcriptional information present in the SA benign biopsies, which aren't even seen as a particularly high risk, can nevertheless accurately predict cancer development more than 10 years later. There are seeds within these lesions that predict whether or not they're going to go on or not. So for the third part of the talk, I wanted to go into more detail about this phenomenon of age-related lobular involution, because I think it's one of the most important things that, oh, sorry.
I just had a question in your part 2 thing.
Part 2.
Were the genes that you identified in the PASH versus the SA, any of them the same or different?
Totally different.
Totally different?
Totally different. But the thing about these gene signature models is that there's many different possible solutions for them that are parallel. So the specific identities of the genes that were in the model are different, but many of them probably could serve as predictors. That's not something we've evaluated though, doing the cross prediction with the different models. So age-related lobular involution, what is it? It's not much studied. It's distinct from post-lactational involution that's been studied a lot, and it's characterized by a progressive loss of epithelial tissue and degeneration of the terminal ductal lobular units. And it begins during premenopause and accelerates during menopause, and it correlates with the reduced risk for milk production after childbearing is complete. So these are whole mounts of premenopausal and postmenopausal breasts, showing in the premenopausal breast the abundant lobular structures, and in the postmenopausal breast the loss of these structures, but the retention of the ducts, which are still present. So we classify lobular involution, age-related lobular involution, in sort of a qualitative fashion. And this is an idealized version of this process for women in their 30s, 40s, 50s, 60s, and 70s. So for women in whom this process has not begun, we classify them as non-involuted. And they're easy to differentiate because there's a very clear definition between intra and extralobular stroma. The acini within the stroma are well organized and are clearly bilayered throughout, and the surrounding stroma is almost all collagenous. As the process of involution gets underway, we classify it as partially involuted, and you can see that the lobules start to become more dispersed. There's a breakdown of the differentiation between intra and extralobular stroma, more fat in the surrounding stroma, increasing number of monolayered acini, until you get to the completely involuted state, where the surrounding tissue is almost entirely fat, and the small remaining lobules are almost all composed of monolayered acini. So when we looked at this qualitative measure of lobular involution in the whole BBD cohort and stratified it by age, what we found was that but for no and partial and complete involution, that those patients with no involution decreased with age, and those patients with complete involution increased with age, as you'd expect. But that there was a substantial number of postmenopausal women in whom this process had not begun or completed itself. And this was striking and important because these women were at substantially elevated risk for subsequently developing breast cancer. So this is stratification for women aged less than 45, 45 to 55, and 55. And in every case, completion of the process of lobular involution is associated with reduction of risk down to below baseline, to below the level of having below the level of having BBD at all. And in the particular case of postmenopausal women, that not initiating the process is associated with a threefold elevated risk, which is a risk level that is the kind that you see in atypia. It's a very high level. And this is interesting for a couple of important reasons. One is that it presents kind of an interesting inversion of the normal relationship between aging and cancer. So aging is normally and is a cancer risk feature, the most important cancer risk feature. Here we have a situation where the failure to age normally or abnormal aging is associated, the retention of premenopausal breast characteristics is associated with increased breast cancer risk. And secondly, it's that this is assessing a feature that's not to do with the index lesion at all. That it's all entirely contained around the index lesion and is not normally considered as part of the risk profile. If we stratify patients by non-proliferative, proliferative disease, or atypical hyperplasia in the index lesion, we see again that the lobular involution status strongly stratifies the risk. And in every case, completing the process of lobular involution, again, this is the tissue surrounding the index lesion, not the index lesion itself that's defining the benign breast disease, is sufficient to drop them back down to baseline. So for those patients who do go on to get cancer, the lobular involution status in the preceding benign breast disease is indicative of the kind of cancers they go on to get. So if they had no lobular involution in their benign breast diseases compared to complete, if they did get cancer, the cancers were more likely to be large, more likely to be poorly differentiated, node positive, and higher stage. So increasing LI status, progressing through the LI process to the complete stage, predicts both decreased breast cancer risk and less aggressive disease in those women who do subsequently develop breast cancer.
What does tamoxifen do to this process?
I would really like to know that.
Because in the patients that are progressing, that are on tamoxifen.
I have been working for the last year to try and set up a clinical trial to define exactly that to answer that question exactly.
Perspective on the patients that did get tamoxifen?
Well, what we've done towards that is assemble together a cohort of women that were diagnosed with atypia or stage 0 breast cancer and who received tamoxifen and then had a subsequent biopsy. And we've identified the patients but haven't pulled blocks yet. So from that, and had tamoxifen for 6 months to up to 2 years, and from that we're going to be able to see what changes occurred in these patients with the tamoxifen, and because they're in part of the system, we'll be able to see whether that's associated with subsequent breast cancer risk or not, whether response to tamoxifen is uniform among women, and whether, if it's not uniform, whether differences in the response are associated with cancer risk. But I don't have anything to talk about that today. We're also setting up a prospective clinical trial in order to try and answer that question too. I think this is the most important question to answer, actually.
This is kind of a related question, but do these data include patients who are on hormone replacement therapy or who were oophorectomized?
I'm sorry, who
were on hormone replacement therapy?
Yes.
Or who were oophorectomized?
Yes and no. So the hormone replacement therapy is included here. We don't have for hormone replacement therapy. We have not a whole lot of granularity of information. We have yes or no and type, but we don't have a lot of information about specifically the timing of it, although we're working up that information now. I have to go back to the clinical records and examine them all individually, and that's a project that's undergoing in our group. It's clear, though, that for patients that do have hormone replacement therapy, that this process is delayed, that the women that have taken hormone replacement therapy are less likely to complete the process of lobular involution for the age that they're at when they had the biopsy. But that's still underway, so I can't say all the details associated with that. The 4 projects that I did think I was going to talk about today, though, are to define how the natural history of lobular involution functions using a new cohort that we just recently put together of women who had multiple biopsies over an extended period of time, identifying molecular characteristics of lobular involution using profiling approaches again, defining the relationship between lobular involution and mammographic breast density, and developing experimentals of lobular involution in which we can break this process down in culture and in animals. So first, tracking the process of lobular involution within individual women. So within the 13,500 women in the Mayo BBD cohort, we identified 1,115 who'd had multiple sequential benign biopsies from ranging between 6 months and 20 years. So we can track the processes that occur, track the changes that occur within individual women over extended periods of time. And because 106 of these women subsequently developed breast cancer, we can assess how these changes are associated with whether or not they had increased or reduced breast cancer risk. So for this study, we assessed the lobular involution using a 4-level lobular involution category on the initial and the subsequent benign biopsies, 0 to 25%, 26 to 50, 51 to 74, and 75 to 100. We did it this way because it sort of roughly divided the initial biopsies into quarters. So there was about a fourth in each of the groups when assessed at initial biopsy. When assessed at subsequent biopsy, this is mixing together all ages of patients and all times between biopsy. Nevertheless, the trend was to push this more towards this end. So whereas they're equally distributed here, you can see that they're predominantly in the final 2 levels of lobular involution status. If we make a table out of this, you can see that it is pushing it down in this direction, that the process is moving it like that. This table, because it includes all ages and all times between biopsy, is a little bit difficult to hack. So I break it out a little bit. Here's a table for women that were less than 45 years at initial biopsy and who had more than 10 years between their biopsies. So these are women that we'd expect to track across the process of lobular involution. And what we see is that they're mostly crowded in this region of the table, which is that they showed low levels of lobular involution at the beginning, at the initial biopsy, and higher levels at the second biopsy, just like you'd expect, and some women who don't fall into this category. For women that were greater than 55 at initial biopsy, they're almost all crowded here. They were mostly involuted initial, mostly involuted at subsequent. So we wanted to see whether the process of lobular involution was associated with whether delays in the process of lobular involution were associated with risk. And to do that, we go back to our big table, and we divided patients out according to whether we felt that they were showing stagnation of LI stasis, versus progression of LI or LI progression. And here's the ones that we counted as LI stasis, and here's the ones we counted as LI progression, and we took out all of them that were fully involuted at initial biopsy because they didn't really have anywhere to go. And when we do this and associate with cancer risk, we see that relative to those that progress normally, that when you're having lobular stasis, that there's significant and substantial elevated risk. So this shows that LI is an ongoing process, and that delays in this process are associated with increased risk, and that we can use these sequential biopsy cohort to track changes within individual women over many years, decades, and correlate those changes here, LI, but it could be anything, to correlate those changes with breast cancer risk. So we're also looking at the molecular basis for increased cancer risk in postmenopausal women. So I've shown you that postmenopausal women, many of them have incomplete lobular involution, up to 40% in the BBD cohort, and that they're at substantially elevated risk for developing cancer. So why is that? Why are they delayed? And why is that associated with risk? To try and get at that, we went back to our profiling approaches. Here we're comparing women that were postmenopausal at their biopsy, and differentiated between those that were non-involuted, completely non-involuted at their biopsy, or completely involuted. So we're pushing it out to the extremes of this profile. And when we looked for the set of differentially expressed genes here, we found that there were many, as you'd expect. And when we did a meta-analysis of this, looked at it and compared it to genes in the literature, we found that were already published that there was substantial overlap for women who were non-involuted by comparison with those that were completely, with other published data sets comparing women with actual breast cancer, comparing stage 3 with stage 1, with highly significant overlap, poorer prognosis, larger tumors, more rapid relapse, and more tumors that were basal by comparison with normal subtype or luminal subtype. So what this suggests is that these high-risk women that don't have cancer nevertheless have gene expression signatures that are characteristic of those that are found in more advanced cancers, poorer cancers, and basal cancers, which are the kind of cancers that are more commonly found in premenopausal women, which is striking given that they're retaining premenopausal characteristics of their breasts. So the gene that was most consistently differentially expressed across these women and in these sets also was TOP2A. So TOP2A is a gene that encodes topoisomerase 2A, which is a strand-passing enzyme that's necessary for cellular mitosis, and it's also the target of anthracycline chemotherapies. We found that in addition to being differentially regulated at the RNA level, that it was also strongly differentially expressed at the protein level. Here, using immunohistochemistry, we saw that there was substantial expression of TOP2A in the lobules of non-involuted postmenopausal women, as opposed to those of completely involuted postmenopausal women. And the extent of expression was actually quite surprising and unexpected to us, because it suggested that these tissues were mitotically active, which was not what we'd been thinking. We'd been thinking that these were like forgotten tissues that had been left behind by the lobular involution process. But TOP2A is most normally associated with proliferation. To assess whether that's so, we looked at Ki-67 and found that it is very high in the non-involuted lobules of these postmenopausal women. Ki-67 indices up to 25%. Which is amazingly high, and that as expected, that there's overlap in the cells that are expressing TOP2A and Ki-67. So this shows that non-involuted postmenopausal tissue, far from being forgotten and left behind, is actually very active, very proliferative, and this is probably a fundamental aspect of their breast cancer risk. So a question you might have been asking is the relationship between lobular involution and mammographic breast density, being that mammographic breast density is one of the best known features of breast cancer risk. So to assess that, we analyzed a cohort of 2667 women that had had a mammogram within 6 months of their biopsy and divided them up using Wolff's parenchymal pattern, which is sort of a qualitative and quantitative measure of breast density for non-dense tissue less than 25, dense more than 25, or homogeneous density. So when we looked at the pattern of lobular involution and mammographic breast density in this group of patients, we saw that both of these features were age associated. So looking just at the bars, which indicate non-involuted, partial, or completely involuted, you can see that those patients that were less than 35 were almost entirely non-involuted or partially involuted, whereas those that were more than 65 were almost entirely partially incomplete, with almost no nons left. And similarly, looking at the mammographic breast density here, indicating the percentage of patients with homogeneous breast density, it goes from about 2/3 for women less than 35 down to about 1/4 for women that are 65 and older. So both of these processes generally track with age. How do they track with risk? What we found is that these two features are independently associated with breast cancer risk. And this table is a bit to take in, so I'm going to break it down. If you look at patients for whom lobular involution is complete and separate them into low mammographic density versus high mammographic density is associated with increased risk for patients with this common lobular involution pattern. Similarly, for partially involuted, higher density is associated with higher risk. For non-involuted, higher density is associated with higher risk. If you hold the density constant and vary the involution status, then completing the process of lobular involution is associated with substantial reduction of risk, even for women that are all having low mammographic density, and similarly, even for women with higher mammographic density, the involution is stratifying risk. So these different features are stratifying separately, showing that they're reflecting separable processes. And as a part of this study, what we discovered was that the normal aging process involves a transition from high lobular content and collagenous stroma and high homogeneous mammographic density to lobular involution, replacement of stroma with fat, and low mammographic density. But it can happen in some women that the lobules can be retained even if the stroma is converted to fat and the mammographic density goes down, so that they retain high breast cancer risk, or that lobular involution proceeds, but the stroma is retained as collagenous, and they have high mammographic density, and these women also have higher breast cancer risk. That these represent distinct endpoints of the aging process, of the high-risk aging process, that could both happen at the same time, but probably have distinct underlying characteristics that are driving them. Finally, I want to talk about experimentally modeling the process of lobular involution. One thing I can tell you is there are no real animal models of lobular involution. So mice, these are mouse mammary glands that over a course of time, they do sort of undergo a process that's kind of like lobular involution. These are cross-sections to their ducts. And the younger mice have the good bilayered ducts, and by the time they get to 18 months, they're all monolayered, so it's a similar process. But we really don't know whether this process is working the same way as in humans, or whether, more importantly, perturbations of this process are associated with alterations of risk, although they're working on that. We've taken a different approach with this. We've characterized a series of primary human mammary epithelial cell lines derived from benign breast tissue biopsies. So this is different from the way most HMECs are derived from reduction mammoplasties. We derived 6 from non-involuted BBD biopsies, 7 from partial, and 6 from complete. And what we found was when we separate these epithelial cells from the tissue context, they nevertheless retain key characteristics of the involution state of the tissue from which they were derived, including the fact that when you grow them in culture, those from non or partially involuted women are substantially more motile, and when you do the gene expression profiles, there's substantial differences in gene expression between patients that were non, partial, or completely involuted. And when we re-inject them into humanized mice to regrow them as lobular structures, HMECs that were derived from partially involuted women grow into more extensive lobular structures. Here they're labeled with GIP to show it's the human cells that are growing out. And those that are derived from completely involuted lobules grow into more sparse lobular structures. So the conclusion of this is that at least some characteristics associated with LI status are retained in the isolated cells even when they're taken out of the tissue context, and that these can be used to develop culture and mouse models, which we can use to break down the process of lobular involution. And the conclusions of the lobular involution process is that lobular involution protects against breast cancer, and it's a physiological mechanism for doing so, and that alterations in this process are associated with increased risk. That lobular involution and mammographic breast density are distinct breast cancer risk features, and alterations in these reflect different high-risk properties of the breast, and that our efforts are working towards defining the biological processes that govern LI. And what we'd like is an LI-based risk assessment model, but really, if we can understand this process, what we'd like to do is to define therapeutic approaches to induce LI in postmenopausal women for whom this process is incomplete and potentially reduce their breast cancer incidence. And the take-homes I'd like to give you from the whole talk altogether are first, that there's really a lot left to know about the initial stages of breast cancer development, that there's key information present in both the abnormal epithelial lesion and in the normal tissue surrounding the abnormal epithelial structure, key inductive information as to whether these women are really at risk, and that BBD is the ideal platform for defining how these processes are integrated in breast cancer development. And with that, I'd like to thank the many people involved in this project, Dan Vischer and Aziza Nassar, the pathologist, Melody Celine Darchanter, epidemiologist, surgeons, breast clinic, biostatisticians, cancer center, patient advocates that keep us on the straight and narrow, funding, and all of you for your time.
I found your comparison of PASH and sclerosing adenosis very interesting, one that involves myofibroblastic proliferation. The two lesions, however, are different in terms of the epithelial contents. We think of sclerosing adenosis as primarily adenosis, epithelial proliferation, and then the stromal component is secondary. So did you think the epithelial proliferation in sclerosing adenosis may participate in the fact that it is precancerous?
I think that's almost certainly the case. I mean, I think this is an example of a difference that is going to be, I think, probably more surprising for basic cancer biologists than for clinicians, for which that answer seemed more obvious from the beginning, that there's a lot of reductionist thinking in basic cancer biology that myofibroblasts are bad, when clearly there's the context of the epithelial tissue, which is the source of the cancer that's important here, and that has to be considered along with it. And that's the point that I wanted to make here. I mean, clearly they're distinct lesions with distinct outcomes, and it's the epithelial tissues that differ. In one case, the epithelial tissues are proliferative, and that leads to cancer, like you'd expect. And in one case, they're not, and it doesn't. But I think that's a critical point.
Sure.
Okay. So, the questions are terrific. So, in the incomplete lobular involution gene expression profiles, is there you looked at the KS67 staining, is there a difference in the apoptotic index?
We haven't looked at the apoptotic index, although I think you really expect that there'd be a lot more apoptosis.
In the ones that are proliferating?
Right, in the ones that are proliferating, yes.
Okay. And then secondly, when they have this residual matrix, is there a drop in the sorts of genes that would cause remodeling of the stroma, collagenases, hyaluronidases?
Yeah, I mean, all the things that are associated with it's the signature is being driven really by the kinds of things that are expressed in proliferating cells, and so all those things are down. You know, the genes for expressing stroma and matrix metalloproteinases are all lower in the proliferating cells. It was surprising, though, because, I mean, in retrospect, I guess it shouldn't have been, because we expected these to be mostly quiescent and to not have that as a defining difference.
Absolutely.
A couple questions. First, I learned from one of our faculty members yesterday, an immunologist that does T cells, he just got a big grant, that there's a subclass of T cells that migrate out into the various tissues, God, wherever, and live there, period. They just stay there, whatever. So I wonder if you have, or others are looking at T cell, NK cells, or whatever in these early stages and following it, because there may be some detente occurring early on and whatever that changes over time.
We are doing this. Just last year we published a study looking at CD8, CD4 macrophages and B cells in the benign tissues and their association with subsequent breast cancer risk. It's, as you'd expect, a super complicated phenomenon. What we see generally is that there's So what we did is compare a set of tissues from the Komen tissue bank. So these are true benigns that were random biopsies with benign samples that did not lead to cancer versus those that did lead to cancer. What we saw, generally speaking, is that there was an increased abundance of immune cells in the benign biopsies that did not lead to cancer. So it suggests that there's maybe an active immune and possibly an anti-cancerogenic process that's going on in these that's lost in the patients that will progress to cancer. Now this is very preliminary because it's done in the most superficial sense. We need to do subtyping of the macrophage subtypes and of individual T cell subtypes, but within these, I think that this is almost certain to be a critical feature. You know, the kind of work that Kaylee's doing is really indicative of the importance of these immune cells for regulating these proliferative processes.
Second question. So it's obvious, very nice work, by the way, that there's a dynamic and reciprocal relationship between the stromal and epithelial cells. Can you speculate on chicken and egg and whatever?
So,
You'd be wrong.
you know, the thing is that it's I mean, all I have is my belief,
Yeah.
right? My belief in this is that it's actually the epithelial, that the non-index lesion component of this that's the most important part. So when we do, I think the lobular involution is the most important stratification feature that we've identified. And when we do the, and so a question that you might have is whether there's a field effect associated with the presence of the atypia or whatever that was at the site. So in order to address this, we took women that had prophylactic mastectomies and did 8-quadrant evaluation, looking at the lesions and also all the different regions, and we found that there was a very high degree of concordance of lobular involution. That is, it's happening everywhere in the breast, and there's not some alteration. I mean, so you could think that bad lesions were leading to retention of epithelial tissue, and that was why there's an association between lobular involution and cancer. But that's not what we saw. We saw that lobular involution is proceeding everywhere about the same, and I think that's consistent with the idea that the subsequent cancers that develop can be ipsilateral or contralateral. I mean, they're coming out of the tissue bed, and it's the tissue bed that's defining the risk profile.
I may have missed this, but what do you know about genetic regulation of breast density?
That's not really my area. There's been studies of heritability of breast density, and I guess my understanding is that the key genes that are associated with this are differences in expression of ER alpha, like you'd expect, and others, but that's not really my main area of expertise. Sorry.
So one corollary or one interpretation of your findings is we should be trying to figure out how to drive lobular involution in those women who do not.
Yes.
So, you know, you couple that with the observation, we treat a lot of breast cancer with estrogen receptor alpha targeted therapies.
Mm-hmm.
We also understand that we reduce the risk of contralateral breast cancer by about half. So have you guys ever looked at whether just thinking about repeated biopsies, I know it's a little tricky to do with contralateral breast cancer on a woman who's getting endocrine therapy for their ipsilateral breast cancer. But have you ever done that to see if the things we currently use drive lobular involution?
What we are doing, like I said, is we've collected together we've identified about 300 patients that had DCIS and that then received the tamoxifen or raloxifene, and then had a subsequent biopsy in the contralateral breast between 6 months to 2 years later. And is this mean I'm out of time? Is this the signal? Time for everybody to go home. Right. So we have the subsequent biopsies from these patients in the contralateral breast, so we can see the effect in the contralateral breast that are benign, and we've identified the patients and are just pulling the blocks now.
So do you think, in the big picture, it's an endocrine-driven phenotype?
I think almost everything in the mammary gland is endocrine-driven, but I think that's almost certainly true. But how it's being done is not clear. I mean, I think that what we're seeing is a differential response to the endocrine environment that's present in these tissues, the lobular involution phenomenon, and what that differential response is probably what's leading to the cancer risk itself. That it's not. I mean, the most simplistic explanation of the relationship would be that because you don't have lobular involution, you have more targets. And when you have more targets, you have more cancer. But I think it's also possible that there's some underlying process that's driving both the retention of the tissue and also the increased cancer risk. And it's this process that we need to target in order to reduce the cancer risk.
So actually, I have 2 questions too, Derek. In the model of lobular involution with the patients, have you actually done any correlation between those patients with delayed lobular involution in later ages and the time of last pregnancy and lactation event in their lifetimes? So do later pregnancies, later breastfeeding lead to later?
Oh, in the whole set, yes,
Yeah.
yes, definitely. So increasing parity and later pregnancies are associated with reduced lobular involution.
Okay.
We did not break that out in the multiple biopsy. Is that what you meant?
Yeah.
We didn't break it out that way for that set yet.
Right.
But for the whole set, yes, it's definitely true that
Definitely kind of a marker of
right.
And then,
Which I think goes towards the idea that the lobular involution, that the retention of the epithelial tissues is not an intrinsic risk feature. So if that were so, I mean, you know that the parity is associated with reduction in risk, but these women are retaining their epithelial tissues. So these tissues are less at risk, even though they're being retained, and that suggests that there's some underlying process that's controlling the risk, and not just the number of epithelial cells.
right. Although there is kind of an inflection of that risk because the risk immediately for the first 5 to 10 years after that last pregnancy is actually higher than the normal non-parent population, and then it dips back down. Suggesting again, I mean, is it in that window as more and more women have children later and later in life that we're essentially moving that back? And then the second question, and I saw Tonio's hand up. Have you looked at ER alpha and ER beta immunohistochemical staining in the lobular involution patient sample set yet?
We haven't done that. We haven't looked at ER alpha and ER beta, except in the context of the atypias.
Okay.
And in the atypias, it didn't have any response for the ER alpha, and it did for the ER beta.
Have you looked at any association between having one or more relatives with breast cancer and the rate of lobular involution?
There's no association with breast cancer risk with the relatives with breast cancer and lobular involution. But lobular involution does stratify in between the different risks. I mean, being a high risk patient is by virtue of having one or more relatives is a higher risk category. But even within that category, lobular involution still stratifies risk. So they seem to be independent features.
Have you looked at methylation in your samples?
Have not done methylation. That is something we're doing now with David Alquist and using similar methods to his Cologuard study.
So I don't know what I misunderstood a little bit. So you're showing that in the lobular involutions that you still see a lot of proliferating cells and epithelial cells. Are you saying that it's as many as before, or it's actually increasing? I mean, there are more proliferating cells compared to younger women. And another question related to that is that I think you're saying that it's the proliferation index correlate with the risk very much, and that if you see a lot of proliferating cells in the lobular, the involutions tissues, and yet you're saying that it's actually reducing the risk of breast cancer, is it?
No, increasing Ki-67 index was associated with increasing risk both in the background tissues, the lobular tissues, normal lobular tissues, and in the index lesion, as you'd expect. And that was specifically true for the SA versus the PASH. So the SA is a proliferative epithelial cells, and the PASH is not. And the SA is a high-risk lesion, and the PASH is not.
Thank you. Last question.
So actually, a handful of years ago, a biostatistician from Mayo gave a really lovely presentation about prostate cancer risk and BPH, and it was a 50,000 cohort group that was put on androgen inhibitors for the BPH, and voila, 25% less cancer 10 years later. So what's the practice at Mayo now with atypia in patients relative to treatment or not? What percentage or whatever?
So the recommendation is for people to take the tamoxifen, but almost nobody does.
Really?
Yeah, it's very, very rare. I think they all should.
It's not going to improve their overall quality of life or quantity of life. I mean, that's a discussion we all have.
I think that I mean, the question of whether or not it's useful for the general population is something that can be argued. But I think it's clear that taking tamoxifen or raloxifene for people with atypia is something that ought to be done. We would substantially reduce breast cancer incidence and mortality if we did this.
Yeah.
I think there's just a bias. The critical problem is there's just a bias now because these women mostly develop ER-positive cancers, and the thinking is, well, we'll just wait for them to get cancer and then treat them then. But I think that's a horrible viewpoint. I mean, I think that we have an option with a drug that's practically free. It's like $200 a year that's going to reduce the breast cancer incidence using known parameters for just using it for, and for that, 2/3 of the people will not get cancer.
So I will just be the devil's advocate. The devil's advocate is that you're preventing breast cancers in a reasonably indolent, and some women will die of stroke and endometrial cancer, and so the overall effect on overall survival might be very minimal. And that is one of the complaints.
That's true for the general population, but the
issue about if you put a prevention strategy and you decrease death rates from that disease, that's never been studied in anything.
But if it's your death rate, it might matter.
Yeah, I mean, I think that's certainly true. That's certainly true for the general population, but for patients with atypia in particular, their risk of cancer is substantially high, and they can prevent it and should.
Well, you just talk to patient advocates of the ED meetings and stuff like that. They will say that they hate tamoxifen.
Right.
They hate being on it.
Yeah.
Other women don't take it because they don't like the way it makes them feel.
I get that. I wish, honestly, I wish that I could do it myself, so I could say that I knew what it was like, but it wouldn't really be the same sort of a thing. This is a good example, but I think it's got to be better than having breast cancer. Even if it's indolent, it's got to be better to have the tamoxifen than breast cancer. One thing that we want to do, and this is the source, this is what our clinical study is designed, it's going to be tried to set up, is to determine whether we really do need 5 years of it. That's one of the major barriers associated with tamoxifen uptake, is that people can't stick with it and they stop after 6 months. Well, maybe 6 months is enough for reducing your risk if you have atypia. Maybe that's sufficient. That's why we want to look at the changes that are occurring after 6 months or 2 years or whatever and correlate that with subsequent risk. Can we stop and take a biopsy at 6 months and say, okay, you want to give it up, but you've already gotten most of the benefit associated with this treatment and you can now stop. I think maybe the uptake would be better if we could do that. So just stick with this for 6 months and then we'll see how it looks.
We got 2 minutes. Last question.
So in your the sets with the data with a high KR67 index, did you make a correlation between infiltration of immune cells, for example, in that region? Is there a direct correlation?
That we have not done.
Because you would expect there would be, one prediction would be there'd be a lower amount of nutrients in there, and you would get lower immune response as a result because of the lack of activation or proliferation of the T cells that would migrate to that region. So there might be a correlation. People are looking at that nowadays. So I don't know about macrophages, but at least for T cells, there is some sort of correlation between a higher level of proliferation of surrounding cells, taking away from the nutrients that are needed for T cell activation.
So I'm not an immunologist, but that's not going to stop me from shooting off my mouth about it. I would probably think that may be true, that there may be a nutrient association with it, but we'd have to look at vascularization as features of these effects. But we haven't looked at this yet.
All right, thank you very much.